relapse rate in both arms, BAT and ruxolitinib, was similar. You are right. If you immunosuppress a patient very severely, it is likely that these patients will have a relapse. But you're immunosuppressing the patient with ruxolitinib, but in the BAT arm, you're using also immunosuppressive interventions like calcineurin inhibitors or e-proteinib or other interventions. So it's not worse than what you're already doing. And the relapse rate was relatively low.
Thank you.
Dear Prof, what I'd like to ask, it has a good action in allogenic. It seems that it may be more major effect when we in haploidentical transplantation.
So you mean that ruxolitinib has a better effect in haploidentical?
Yes, in haploidentical transplantation. Has it more major effect than that of allogenic?
No, there's no evidence that it has more effect in haploidentical transplantation.
Still, we have 5 minutes. Looking for more questions if we have. Please give the mic to the next one. Dr. Ahmed, you want to ask again?
No, thanks.
Okay. At the end of the session, I would like to thank our distinguished Prof for this interesting and highly informative session, hoping more sharing data with him and more in the coming future. So I will stop the session right now and go into the next one.
Thank you very much. It was a great honor to be here and to be part of this interesting conference. Thank you very much and have a good conference.
Thank you for
Now, good afternoon, everyone. Now, the next session will be of some different flavor, in fact. We are honored today to have a distinguished speaker from England, who is Dr. Raj Patel. Dr. Raj Patel is a consultant hematologist, and his main interest is in thrombosis and hemostasis. Dr. Patel trained at King's College in London. He spent 5 years in hematology there under training, and it was at that time when he developed a research interest in the coagulation field. In fact, his first interest began to appear when he was interested in thrombosis and liver disease. Dr. Patel works within the Clinical Thrombosis Center at King's College in London, and his main research interest is the VTE, anticoagulation, thrombophilia with ethnicity, and thrombotic liver disease. He is the training program director for hematology in the southeast of the Thames in England. And just to tell you how active he is, in fact, on average, he writes about 50 reports a year. Dr. Patel will kindly update us on a very, very interesting topic, which was till recently very under-recognized. It is the cancer-associated thrombosis, and which anticoagulant do we need for cancer once they develop VTE? Dr. Patel, please.
Thank you very much. I hope you can all hear me. Thank you, Mr. Chairman, for that introduction, very kind introduction. It's a great honor to be asked to speak here. Thank you also to Dr. Faraz Al-Faraji, an old friend of King's who was here for some time, who has many friends here, and to Dr. Abdeen for inviting me formally to this conference. I work at King's Thrombosis Center. We have a very large hematology unit with 35 consultants specializing in different areas of hematology. My interests are cancer thrombosis, liver disease and thrombosis, and pregnancy, although most lately my main interest has been COVID-19 thrombosis, given the high numbers we're seeing in the intensive care unit, possibly immunothrombosis due to the virus in the pandemic. But today we're going to talk about which anticoagulant for cancer VTE. These are my declarations, mainly educational speaker meetings for the drug companies that produce the direct oral anticoagulants. So today there'll be 4 parts. First of all, just to touch the epidemiology of cancer-related thrombosis, or CAT. Then we'll focus on primary prevention, thromboprophylaxis, patients with cancer. How does one prevent them getting either a surgical DVT or a medical DVT when they have a diagnosis of malignancy? So low-dose prophylaxis. Then how does DVT or pulmonary embolism present in cancer? And then how do we treat it? Should we be using warfarin? Should we be using low molecular heparin? And what is the role of DOACs, the direct oral anticoagulant, in prevention and treatment? And at the very last, I'll give you a few slides on the current guidelines. What do the ISTH say? And what does ASCO recommend for cancer-related thrombosis prevention and treatment? So that's an introduction. We all know the first link of cancer and thrombosis, which was Trousseau in 1865. And Trousseau described the case of abdominal cancer and migratory superficial vein thrombosis, not DVT, a superficial thrombophlebitis. And we know there's a strong association with those two. Earl Trousseau then developed thrombophlebitis himself, aged 66 years, and died of pancreatic cancer. And there's a two-way relationship between cancer and thrombosis. Patients with cancer are at higher risk of developing VTE than the general population. But also, if you present with an unprovoked proximal deep vein thrombosis or pulmonary embolism, around 5 to 7% of patients will go on to develop a new cancer, having not had a cancer diagnosis when the DVT was diagnosed. So there's a predictive value for developing cancer, most of those being occult malignancy at the time of VTE diagnosis. So the VTE risk is increased around 4 to 7-fold, depending on which cancer you look at. Around 10 to 20% of patients with cancer will develop a VTE at some point. Some of those obviously line-related from intravenous lines, but others DVT, PE, and phlebitis. And in the Wright registry, looking at about 15,000 patients with VTE, about 20% of the cohort cancer. So if you look at an idiopathic DVT that's without cancer, and then you look at 12 months, well, about 5% will have developed one, developed the cancer. And these are more likely to be disseminating, aggressive, and have a significantly lower time than patients with VTE who don't have cancer or cancer who don't have VTE. VTE is the second leading cause after cancer itself in these patients. I'm not going to talk much about pathogenesis. This has been well described. Essentially, pathogenesis relates to intrinsic properties of the tumor cells, the interactions of these cells with, yes, someone's saying the sound is not clear. I hope that's a little bit better. Interaction of tumor cells with endothelium and monocytes and the secretion of cytokines by tumor cells. And the clinical risk factors for cancer-related thrombosis are tumor, patient, or treatment-related. So the tumors with the highest relative risk tend to be brain, pancreas, stomach, ovary, of early duration, so within 3 months of diagnosis, those that are high grade, advanced, with biomarkers positive. The patient-related risk factors are the usual ones, for example, immobility from surgery or previous venous thrombosis or thrombophilias. And cancer-specific include high counts, high white count, high platelet counts, and the surgery and pharmacology we give these patients. For example, cancer surgery and the pharmacological treatments. Erythropoietin, tamoxifen and thalidomide, for example. So the distribution of VT by cancer site, well, this can be slightly misleading because even though pancreas, head and neck have that relative risk, you actually see many more cancers in the breast cancer population have a lower relative risk, and that's because the breast cancer and others are more common. So remember that even though the risk in the individual pancreas patient will be high, as a whole, you'll see many more different populations because the numerical number of patients with cancer and other cancers with lower incidence. So as you look at a cancer patient that presents to you, the relative risk is high at diagnosis and then increases as you hospitalize them and give them active chemotherapy. Chemotherapy will cause cancer cells to lyse and cancer procoagulant flows into the blood, which is very like tissue factor, and the tissue factor trips the clotting cascade and causes a thrombin burst, causing thrombosis. So hospitalization, immobilization, and chemotherapy all increase the risk over baseline in the cancer diagnosed patient. As the tumor bulk reduces, of course, the relative risk reduces until remission. Still is slightly higher than baseline. And then at relapse and end of life, up the relative risk goes again. But generally speaking, the relative risk remains higher than that baseline risk in the general population throughout the journey. What about patients who come in with unprovoked proximal DVT or PE? Should we be screening them for cancer? Originally, the UK NICE guidelines said we should, but actually the pickup rate is very low if you screen them even aggressively. Only % will go on to have a cancer in the next 12 months. In the UK, what we will do is a patient with an unprovoked proximal clot, we will do a careful history examination, simple blood tests, and we will only investigate them aggressively if they have signs and symptoms to investigate. Otherwise, we have a high clinical suspicion over the next 12 months, but won't aggressively investigate them because there's no evidence it changes their outcome with aggressive investigations to look for occult malignancy. I'm sorry, I'm seeing the chat box is seeing lots of echoes. I can hear echoes in my own earpiece. I don't think it's coming from my side. Yeah, that seems much better. So the next part is prevention of VT in patients with cancer. What about hospitalized surgical and non-surgical patients, the ones that are in hospital? Well, we know that hospitalized patients in cancer have probably a 4 to 7% risk of having a DVT. That's medical and surgical patients. There's a twofold increase in post-operative VT compared to non-cancer surgery. And the risk after surgery probably persists for 6 to 7 weeks, even after hospital discharge. We know that patients with cancer who have surgery are at higher risk than non-cancer patients with surgery, probably double risk. And we know that if you look at VT in those populations and thromboprophylaxis is probably around twice as effective in the cancer patients. So cancer patients are at higher risk after cancer surgery, and thromboprophylaxis is more effective than those who don't have cancer. So we know we have highly effective methods of prevention. In fact, if you look at studies like anoxacan, if you prolonged prophylaxis after hospital discharge, because of course many DVTs in abdominal pelvic cancer will occur after hospital discharge, then of course you get a more than 50% recurrence reduction with extended prophylaxis, which is why in abdominal and pelvic cancer surgery, we tend to discharge patients with longer-term low molecular prophylaxis for up to 6 weeks. What about patients who are not surgical? So what about patients who are ambulatory cancer outpatients? Should we be giving them something to reduce the risk of thrombosis first occurring? Well, there are a number of studies, and the bottom line is that generally most thromboprophylaxis reduces the risk in ambulant chemotherapy patients by about 50%. The Cochrane review quotes about 46% risk reduction, and other meta-analyses, including those in lung cancer. If you give ambulant patients daily heparin prophylaxis, you reduce their risk of DVT and PE by about 50%. Some studies in high-risk cancer patients, such as pancreatic surgery, suggest a bigger risk reduction, maybe near 90%. These are small studies. Of course, what you want to know is what about the DOACs, the new anticoagulants. And the new anticoagulants, apixaban and rivaroxaban, have been trialed against low molecular heparin to try to prevent DVT in cancer patients. And these studies have used the Corona score. And in patients with the Corona risk score 2 or more, these patients were randomized to either having thromboprophylaxis as an outpatient with heparin or with either low-dose apixaban or rivaroxaban. This is the AVERT study, where apixaban was used, 2.5 milligrams twice daily for 3 months, to look versus dalteparin, a prophylactic dose. And if you look at this study, essentially brain tumors and metastases were included. Around 574 patients, mainly lymphoma and gynecological cancer. There was no screening. This was symptomatic events they looked for. And essentially, if you look at the VTE rates, the apixaban reduced the rates of VTE compared to heparin prophylaxis by about 60%. Highly effective and more effective than molecular heparin. And interesting, the major bleeding weights were about double. So yes, you get a reduction by about 6%. 60% risk reduction, 6% absolute risk reduction using the DOAC compared to low molecular heparin prophylaxis in ambulatory chemo. But that's offset by a 2% risk in major bleeding. Similarly, the Cassini study with the rivaroxaban 10 milligrams did very similar things. These excluded brain tumors and metastases, and many of these were high-risk tumors, pancreas and GI. And here they were baseline scans. So they had a baseline scan and serial scanning. So this was symptomatic and asymptomatic clot they looked for. And here they were about a 40% risk reduction in VTE on the intended to treat arm. But on treatment, it was around a 60%, similar to the other study with apixaban, around a 60% reduction in symptomatic and asymptomatic DVT, with again, rough 2% increase in major bleeding. So we know that the DOACs are as effective, if not more effective, than low molecular heparin in preventing DVT in these ambulatory cancer patients. That's offset with a cost, and the cost is a 2% in major bleeding. So as a whole, what we have is low molecular heparin studies showing you can reduce the risk by about 50%. And the new agents, rivaroxaban and apixaban, showing you can reduce the risk around 60–65%, but the bleeding risk is double when you give outpatients, ambulatory chemotherapy patients, thromboprophylaxis. So what does that mean for what we actually do? Well, in the UK, it really hasn't caught on. We are not using Corona scores in the UK. We are not giving ambulatory cancer patients, non-surgical ones, medical patients, thromboprophylaxis, unless they have myeloma or on thalidomide derivatives. Giving surgical patients thromboprophylaxis as inpatients, and the abdominopelvic patients will get thromboprophylaxis on discharge. The jury is still out regarding thromboprophylaxis for ambulatory medical patients with cancer. We are not yet following ESCO guidance and offering, for example, pancreatic cancer patients routine prophylaxis with rivaroxaban at low dose or apixaban. Not yet. So what about clinical thrombosis? How does it present in cancer patients? Well, of course, it ends with symptomatic DVT and PE, but also as scanning gets more frequent and better, we see a lot of incidental VTE, asymptomatic on staging scans. And what on earth do we do with a subsegmental PE that we see on a staging CT scan? Do we treat it or not? We get a lot of catheter related thrombosis, either with these PICC lines where you get superficial phlebitis after breast cancer treatment, or deep vein thrombosis related to catheters. And of course, superficial phlebitis even without catheters. So those are the general presentations that we see for symptomatic DVT. So I'll start with incidental VT. What about patients who are not symptomatic, but when you scan them for staging, you happen to find either a DVT, a line-related clot, or a pulmonary embolism, completely asymptomatic? Well, the question is asked, do we really need to treat those patients? Several studies have suggested a similar clinical outcome to those with symptomatic VT, so I don't think they do any better. In other words, if you don't treat them, they will behave the same as VT and have a higher recurrence risk. In fact, the Hokusai cancer study and Selecti, and these were the treatment studies with DOACs in cancer, 30 to 50% of patients had incidental VTE in those cohorts. And in the Hokusai cancer study, if you looked at the 340 patients with incidental asymptomatic VTE, they had a similar rate of recurrence and major than those with symptomatic events. So they actually behave very similarly. I don't think that's the case for non-cancer patients. If you get a general medical patient who has a small subsegmental incidental clot, I think there may be different natural history, but in cohorts, the incidental clots seem to do just as badly as the symptomatic clots, so we treat them the same. And the guidance suggests that most patients with incidental clots should be treated as patients with symptomatic clots, treat them the same. Those with just a single isolated subsegmental PE, no DVT and ultrasound, case-by-case basis. And if that patient has a high bleeding risk, you withhold anticoagulation and watch them very carefully. Generally speaking, we would treat them. So what treatment options do we have when we treat cancer-related thrombosis? Well, here are the 5. Heparins, which were the mainstay of anticoagulation for many years. Unfractionated heparin hardly used, mainly for patients who are inpatients with renal failure. Fondaparinux, which is pentasaccharide and can be used where patients have heparin thrombocytopenia, or if patients object to porcine heparin when treated. Vitamin K antagonists still have a role in patients with significant renal impairment. And the DOACs. I'll focus the latter end of my talk on whether DOACs should be used and in whom they should be used. So low molecular weight heparin followed by a vitamin K antagonist was no longer the standard of care many years ago now. We know that you get high rates of bleeding in cancer patients on vitamin K antagonists. And in fact, warfarin causes a lot more recurrent thrombosis than does low molecular weight heparin. So warfarin's not as effective as heparin in cancer thrombosis and probably is associated with increased risk of bleeding. And the problems of warfarin cancer include all the drug interactions, bioavailability with malnutrition, vomiting, and diarrhea that you get with vitamin K problems. Patients with liver dysfunction, the INR control is very difficult. Of course, the warfarin resistance syndrome, and patients with adenocarcinoma, if you treat them with warfarin, you get about 20% breakthrough, probably because of cancer procoagulant overwhelming the vitamin K's ability, vitamin K antagonist ability to treat that cancer-related thrombosis, which you don't see with heparin. It's less effective. Major bleeding is probably higher. Get all the monitoring problems, and it's very difficult to know what to do with warfarin when the platelet count drops, either on warfarin or off it. There's no easy titration for the INR with thrombocytopenia. And in fact, the reason we use low molecular weight heparin so widely is because it's a very small study. I mean, 676 patients only clot study. And these patients were randomized to dalteparin at full dose, then 3/4 dose after a month, compared to warfarin antagonists. And in this clot study, which is the seminal study, we saw that with dalteparin, the risk reduction for recurrence was half. And that drove the big use of dalteparin across the world. After this was published in 2003, with no difference in mortality and very similar bleeding rates. So actually in this study, it was the efficacy of the low molecular weight heparin really changed practice globally, and low molecular heparin very quickly became the mainstay of treatment for cancer-related thrombosis. More recently, this has been replicated in something called a study where tinparin was used against warfarin in cancer VTE. And here you see the rates of symptomatic VTE significantly lessened, the same as the clot study, about half in the tinparin arm compared to the warfarin arm, with a very significant reduction in clinically relevant non-major bleeding too, but no change, no major bleeding. So we're not really using heparins because of the bleeding advantages. They may not be that strong. We're using it because they're highly effective compared to warfarin, twice as effective. So the good thing about using low molecular heparin is that, generally speaking, it doesn't need monitoring. There's almost no chemotherapy interactions. When you get thrombocytopenia, you can titrate the heparin dose, and we have guidelines to help us do that. You can give it when patients have nausea and vomiting, no problem, it's parenteral. And generally speaking, we give 6 months, and then ongoing treatment until the cancer treatment has been completed and the cancer is in remission. Only if heparin can't be given do we look for fondaparinux. I mean, you can't use that in renal failure because it's highly renally cleared, warfarin, or a direct oral anticoagulant. So the use of DOACs in cancer VTE, could we stop using heparin, inconvenient injections, and start using a tablet to treat cancer-related thrombosis? And that's what we've been trying to do for a number of years now. Now, what were the initial concerns? The initial concerns were that there are drug interactions that you can't easily monitor for when you're using the direct oral anticoagulants, such as rivaroxaban and apixaban. With low molecular heparin, there aren't any. With warfarin, you can monitor the INR, but for these drugs, you can do drug levels. It's not that easy to do and not mainstream to be monitoring these drugs. And when patients are on strong inhibitors or inducers of P-glycoprotein or CYP3A4, you can get a reduction in the DOAC levels or an increase in the DOAC levels, predisposing patients to possible breakthrough clot or bleeding. And there are many lists and websites which will list various chemotherapy agents and potential interactions. And if you see one of those interactions, for example, tyrosine kinase inhibitors, you may try to avoid a DOAC in those situations. The problem with DOACs is the mucosal bleeding risk. We use DOACs in general patients because the intracranial bleeding risk is half, for example, in atrial fibrillation. But what DOACs do give us is one bad side effect, and that is mucosal hemorrhage. In most studies, people complained of nuisance bleeding, oropharyngeal, hemorrhagia, and other upper GI bleeding, probably more than you see with warfarin. So one problem is that if you have a mucosal lesion, such as a gastric ulcer or a gastric tumor, you will be at risk, probably more than you would be with warfarin or heparin, for a mucosal bleed. So we tend to avoid the DOACs with mucosal hemorrhage. And of course, patients sometimes do have a mucosal bleeding risk. And the parenteral agents obviously are good for patients with nausea and vomiting and chemotherapy. Oral agents are not so good. Now I've mentioned thrombocytopenia, I thought I'd take this opportunity just to show you a slide of what we do with heparin and thrombocytopenia. And patients who have a deep vein thrombosis in context of cancer, we're trying to anticoagulate with low molecular heparin. If it's a large recent clot at high risk recurrence and mortality, so a large PE or large proximal DVT, certainly in the first month, we would continue the full doses of low molecular heparin, perhaps split into half in the morning, half in the evening, but full dose anticoagulation. And if a platelet count dropped below 50 because of chemotherapy or marrow impairment from tumor, we would support the platelet count with platelet transfusions for the first at least 3 or 4 weeks, major thrombosis. To that we said. But for patients who have a lower risk, for example, a small volume clot or a line-related clot that is unlikely to cause significant morbidity if it recurred or extended, we would possibly, at platelet count of 50, we would reduce to a prophylactic dose of heparin, and below a platelet count of 30, we would stop low liquid heparin. So it really depends on the size and the risk of the clot that you see. For the high risk fresh clots of shorter durations, of shorter time period, 3 or 4 weeks from diagnosis, I would treat with full doses and platelet count transfusions. After that, for smaller clots, you might reduce the prophylaxis when the platelet count drops below 50, stop when the platelet count drops below 25 to 30. And this is the ASTH SST guidance on thrombocytopenia with full dose and intermediate dose heparin. So what about using apixaban, rivaroxaban, edoxaban to treat cancer thrombosis? Do we really need to use low heparin at full dose for 6 months plus? Well, luckily we have 3 good studies now, all randomized trials, which help us answer that question. The latest one was the Caravaggio study, and I'm going to go through the specific details of each of these. I'm going to give you the headline news. And of course, this non-inferiority study randomized patients to standard dose of apixaban, 10 milligrams twice a day for a week, 5 milligrams twice a day thereafter. That's the dose we use for DVT treatment, standard dose, compared to doxycycline at the standard clot doses. And at 6 months, looked at this study, then the recurrent VT risk was slightly lower on apixaban than dalteparin. Certainly is non-inferior and probably superior, hazard ratio of 0.63, superiority for apixaban. No increase in major bleeding, probably a reduction in later bleeding. So that was very promising with apixaban compared to low heparin. Is this an apixaban effect or is it a class effect? Do all the 10A inhibitors give us this? Well, the other 10A inhibitor is edoxaban. And this is the Hokusai cancer study. Again, edoxaban at full DVT doses, either 60 or 30, depending on renal function and body weight, 60 milligrams or 30 milligrams, compared to low liquid heparin, compared to dalteparin. And in this study, you see that with edoxaban, 4% decrease in VT recurrence on treatment compared to dalteparin, so it's superior. And that is offset by a 4% increase in the major hemorrhage risk, mainly upper GI tumors. So here we see that edoxaban has better efficacy than our gold standard dalteparin in treating TMP in this cancer cohort. That's offset by an increase in major hemorrhage, but mainly from the upper GI tract. And lastly, the rivaroxaban study, which is the SELECT-D study, which again showed when you compared rivaroxaban at full dose to dalteparin, a 7% decrease in VT recurrence risk, so a superiority there for the DOAC. However, bleeding risk, the clinically relevant non-major hemorrhage risk was 7% higher. So again, mainly upper GI bleeding. Remembering when you look at these studies